Venous drainage. Systemic venous drainage. CAM, as the name suggests, it's a malformation of adenomatoid stuff that replaces normal lung. Most of the time it only affects one lobe. There is no lobar preference, unlike CLE, which favors the left upper lobe. There are cystic and solid types, type 1 cystic, type 3 solid, type 2 in the middle. There is a crop of knuckleheads who want to call these things CPAMs and have 5 types, which I'm sure is evidence-based and will really make an impact in the way these things are treated. CCAMs communicate with the airway, and therefore fill with air. Most of these things, like 90%, will spontaneously decrease in size in the 3rd trimester. The treatment, at least in the US, is to cut these things out, because of the itty-bitty theoretical risk of malignant transformation, pleuropulmonary rhabdomyosarcoma. Q. What if you see a systemic arterial feeder, one coming off the aorta, going to the CAM? Oh, then it's not a CAM, it's a sequestration. Sneaky. 3. Section 6. Cystic lung disease. Pulmonary Langerhans cell histiocytosis, LCH. This cystic lung disease classically affects smokers, who are young, 20s-30s. The disease starts out with centrilobular nodules with an upper lobe predominance. These nodules eventually cavitate into cysts which are thin-walled to start, and then some become more thick-walled. Late in the disease you are primarily seeing cysts. The buzzword is bizarre-shaped, which occurs when 2 or more cysts merge together. In about half the cases this spontaneously resolves, especially if you stop smoking. Another piece of trivia is that LCH spares the costophrenic angles. Times 11J. What spares the costophrenic angles? ILCH and hypersensitivity pneumonitis. L. Lymphangiomyomatosis, LAM. This cystic lung disease can occur in childbearing aged women or in association with tuberous sclerosis. A trick is to show the kidneys with multiple AMLs first. The cysts are thin-walled with a uniform distribution. There is an association with chylothorax, which is high-yield trivia. The pathophysiology is that it is estrogen-dependent, why it strongly favors women. This is usually progressive despite attempts at hormonal therapy, tamoxifen. LCH LAM cysts and nodules. Smoker cysts, no nodules, women. Points with tuberous sclerosis. Upper and mid lungs. Diffuse thicker cysts. Thin round cysts. Bizarre. Birt-Hogg tube, BHD, this is a total zebra. This cystic lung disease has thin-walled oval-shaped cysts. There is an association with renal findings, bilateral oncocytomas, and chromophobe RCCs. They also have a bunch of gross skin stuff. Birt-Hogg tube oval cysts. LCL. Bizarre eye thick shape wall. LAM round thin wall. BHD oval thin wall. LAM multiple thin-walled round cysts. 328. Lymphocytic interstitial pneumonitis, LIP. This is a benign lymphoproliferative disorder, with infiltration of the lungs. It has an association with autoimmune diseases, SLE, RA, Sjogren's. The big one to know is Sjogren's, which is concomitant in 25°/O of LIP cases. The other one to know is HIV, which is the LIP in a younger patient, children. LIP in HIV-positive adults is rare. There is also an association with Castleman's. The appearance of LIP varies depending on the underlying cause. The cystic lung disease is usually thin-walled, deep within the lung parenchyma and seen predominantly with Sjogren's. The dominant feature described as ground glass or nodules is seen more in the other causes and is far beyond the scope of the core exam. When I say LIP, You say Sjogren's and HIV when I say lip in a kid. You say HIV. Pneumocystis pneumonia, PCP, this is the most common opportunistic infection in AIDS. The typical buzzword is ground glass appearance, predominantly in the hilar and mid-lung zones. Pneumatocells are present in 30% of cases. In patients receiving aerosolized prophylaxis, a cystic form is more common, which may have bilateral thin-walled upper lung predominant cysts. Gallium-67 scan will show diffuse uptake, thallium will be negative. When I say AIDS and ground glass lungs, you say PCP. 329. Emphysema. The textbook definition is permanent enlargement of the air spaces distal to the terminal bronchioles accompanied by destruction of the alveolar wall without clear fibrosis. What you need to know are, 1. The CXR findings and, 2. The different types. CXR findings. Until it's really bad, CXR doesn't have direct signs, but instead has indirect signs. Flattening of the hemidiaphragms is regarded as the most reliable sign. The AP diameter increases. The retrostomal clear space becomes larger. There is a paucity of, or pruning of the blood vessels. Types. Ocentrilobular, by far the most common type. Common in asymptomatic elderly patients. It has an apical to basal gradient, favoring the upper zones of each lobe. It appears as focal lucences, located centrally within the secondary pulmonary lobule, often with a central dot representing the central bronchovascular bundle. This central dot sign is a buzzword. This is the type of emphysema dominant in smokers. Opanlobular, in contradistinction to centrilobular, this one favors the lower lobes. It also has a more uniform distribution across parts of the secondary pulmonary lobule. The association is with alpha-1 antitrypsin. A piece of trivia is the Ritalin lung from 4-Ritalin use can also cause a panlobular appearance. Ritalin keeps you from TRYPSN out. If they show this, it will be in the coronal view on CT to demonstrate the lower lobe predominance. Patients will present in their 6, S and 70s, unless they smoke, then they present in their 30s. Smoking accelerates the process. Oparaceptor / this one is found adjacent to the pleura and septal lines with a peripheral distribution within the secondary pulmonary lobule. The affected lung is almost always subpleural, and demonstrates small focal lucences up to 1 ohm in size. This looks like honeycombing but is less than 3 bubbles thick. Trivia. O saber sheath trachea, diffuse coronal narrowing of the trachea, sparing the extrathoracic portion. This is said to be pathognomonic for COPD. If the main PAR is larger than the aorta, COPD patients have a worse outcome. Pulmonary HTN can be caused by emphysema. Surgery to remove bad lung volume reduction is sometimes done. 330. Vanishing lung syndrome. This is an idiopathic cause of giant bullous emphysema, resulting from a vascular necrosis of the lung parenchyma and hyperinflation. It favors the bilateral upper lobes, and is defined as bullous disease occupying at least 1/3 of abmithorax. The most common demographic is a young man. About 20% of these guys have alpha-I antitrypsin deficiency. Compensatory emphysema, post-pneumonectomy syndrome. There is no obstructive process here. Instead you have hyperexpansion of one lung to compensate for the absence of the other one. Honeycomb lung. When I say honeycombing you should say UIP. However, this is seen with a variety of causes of end-stage fibrotic lung processes. The cysts are tightly clustered, 2 to 3 rows thick, and subpleural. The walls are often thick. 331. Section 7. Pneumoconiosis. As a general rule, these are inhaled, so they tend to be upper lobe predominant. You can have centrilobular nodules, which makes sense for inhalation, or often perilymphatic nodules, which makes a little less sense, but is critical to remember especially with silicosis and CWP. Asbestos exposure. The term asbestosis refers to the changes of pulmonary fibrosis, not actual exposure to the disease. The look is very similar to UIP, with the presence of parietal pleural thickening being the most important feature to distinguish between IPF and asbestosis. Obviously, the history of working in a shipyard or finding asbestos bodies in a bronchoalveolar lavage is helpful. Things to know about asbestos. Asbestosis equals the lung. Fibrosis associated with exposure, not actual exposure. Interstitial pattern looks like UIP plus parietal pleural thickening. There is a 20-year latency between initial exposure and development of lung cancer or pleural mesothelioma. There is an association with extrapulmonary cancer including peritoneal mesothelioma, GI cancer, renal cancer, laryngeal cancer, and leukemia. Benign pleural effusions are the earliest pleural-based phenomenon associated with exposure, still with a lag time of around 5 years. B11 IgN asbestosis-related changes. Pleural effusion is the earliest and most common. Pleural plaques may develop around 20 to 30 years, with calcifications occurring around 40 years. These plaques tend to spare the apices and costophrenic angles. ROU11D atelectasis, which is associated with pleural findings, is sometimes called the asbestos pseudotumor. Malignant mesothelioma. The most common cancer of the pleura. About 80% of them have had asbestos exposure. And development is not dose-dependent. The lag time is around 30 to 40 years from exposure. The buzzword pleural rind is worth knowing. The tendency is for direct invasion. Extension into the fissure is highly suggestive. 332. Silicosis. This is seen in miners and quarry workers. You can have simple silicosis, which is going to be multiple nodular opacities favoring the upper lobes, with eggshell calcifications of the hilar nodes. You also get perilymphatic nodules. The complicated type is called progressive massive fibrosis, PS. Pleural findings is sometimes called the asbestos pseudotumor. Malignant mesothelioma. The most common cancer of the pleura. About 80% of them have had asbestos exposure. And development is not dose-dependent. The lag time is around 30 to 40 years from exposure. The buzzword pleural rind is worth knowing.